another minute for people to come in, and then we will get started. All right, I think we can get started now. Hello, everyone, and welcome to the NDARC weekly webinar. My name is Calvert Tisdale. I'm a postdoctoral research fellow here at NDARC, or the National Drug and Alcohol Research Centre, and I'll be chairing the webinar today. Before we get started, I would like to just begin by acknowledging the Bidjigal and Gadigal people, who are the traditional custodians of the land from which I am joining this webinar today. But I would also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience may be joining from different locations across Australia. And I'd like to pay my respects to the elders past, present, and emerging, and also extend that respect to any First Nations people who are present today in the webinar. So today we're going to be hearing about suicide by poisoning in Australia, patterns of medicine usage and targets for means restriction from Dr. Jessy Lim. And I'm very excited to introduce our speaker today, as Jessy Lim is actually a colleague of mine and also a postdoctoral research fellow at NDARC. Her research primarily focuses on safe medicine use and reducing medicine harm, and she comes with a background in pharmacy, so will provide a very unique and interesting perspective on this issue. Jessy will also be joined for the panel discussion today by Dr. Rose Cairns. Dr. Rose Cairns is a lecturer at the School of Pharmacy from the University of Sydney and has a clinical role as senior poison specialist for research and auditing at the New South Wales Poisons Information Centre. So, without further ado, firstly, I'll just say we're going to have time for questions at the end, so please put them in the Q&A function. We won't be able to see them in the chat if you do put them there, but the Q&A, I'll be able to see them and present them to both Rose and Jessy following the presentation. So I may not get to them all, but I will endeavour to ask as many as possible. So without further ado now, I would like to invite Jessy to turn on her camera and take it away. Jessy.
Okay, thank you, Calvert, for the introduction. Can I confirm that people can see the slides and hear me okay? Okay, so thank you. So as Calvert has mentioned, I am a postdoctoral research fellow at NDARC, and I'll be presenting on my PhD, which was completed late last year at the University of Sydney. Please note that my presentation does discuss suicide in detail, so if you find any of the contents distressing, please talk to somebody that you trust or contact Lifeline with the SMS or phone number here. It is also okay to take a break if you need to, as this presentation is recorded. So I will be presenting on my PhD, which was divided into 3 core papers. So my first paper was a systematic review of means restriction of poisons, and my later papers will examine substances detected in suicides in Australia. Suicide is a significant cause of death worldwide, with at least 800,000 suicides occurring every year. 77% of suicides occur in low and middle income countries. However, suicide risk, thoughts, and behavior are generally short term, and many suicides do occur during an impulse. So suicide prevention works on multiple levels. So on a population level, there is means restriction. So examples of this are bridge barrier and gun control. So these interventions have been associated with a decrease in suicide by those methods. There are also media guidelines. And then on an individual level, there are crisis hotlines, medical and psychological treatments. So our systematic review focused on restriction of poisons. So means restriction refers to changes in the environment that reduce access to lethal methods of suicide. Or another way of saying it is that they reduce access to the means of a suicide method. So its purpose is to lower the probability of a suicide attempt, delay a suicide attempt, or lead to a change in method where an individual may use a less lethal method than a method that they might have originally had in mind. And overall, there is a better chance of survival and rehabilitation. Means restriction is also good because it can target people who have not sought out help yet during a suicide crisis. So some examples of lethal poisons include pesticides, where paraquat is a well-known pesticide because a very small amount is fatal if it is ingested. And a lot of other pesticides are classified by the World Health Organization as extremely or highly hazardous. Gases include carbon monoxide from domestic gas and motor vehicle exhaust. So these can be potentially fatal poisons when they are inhaled in a closed room, as well as some other gas cylinders that people may obtain. And then examples of medicines include opioids, barbiturates, and hypnosedatives. So we did a systematic review to ask what is the association between means restriction and suicide rate. So we combined our mesh terms and keywords to search 5 databases, and we had a search strategy that combined the concepts of suicide with poisons, which was both general terms of poisons as well as some specific poisons that we knew of, and also restriction with words such as intervention and policy. So the intervention had to be included if it was done at a national or country level. So the aims of our study were to evaluate changes in suicide by the specific poison. So that was our outcome of interest. But we also evaluated changes in other methods of suicide, which was basically the overall suicide rate minus the suicide rate by that restricted poison. So this is the standard Prisma diagram, which is done for systematic reviews. So after removing duplicates, we screened about 7,600 articles, and we had about 60 articles to be included in the study and about 29 articles which were suitable for graphing and comparisons. So this is the bubble map, which quickly shows where the studies were conducted. So we had studies in 26 countries, and most were in Europe, North America, Asia, and Australia. However, it's important to note that even though most suicides occur in low and middle income countries, the research is not being published there. And we did not find any studies in South America or Africa. So some interventions which can reduce poisoning include withdrawal or ban, where a medicine or chemical is taken off the market. It can also be made in a reduced concentration or quantity, and this limits how much of a poison can be ingested in an overdose. There's also occupational license, where access to a poison is restricted to a certain job, or therapeutic restriction, where a medicine is restricted to a certain medical condition. And there's also physical barrier, such as a locked storage box. So the graphs here show incidence rate ratio. So we calculated incidence rate ratio as the suicide rate after the intervention divided by suicide rate before the intervention. So because our studies occurred in different time periods, we standardized this to a 5-year follow-up period. So on the forest plots here, we've got our incidence rate ratio. So if the ratio is less than 1, it suggests a decrease in suicide after the intervention. But if the ratio is greater than 1, it suggests an increase. And if the confidence interval crosses 1, it's not statistically significant. So our example here is for medicine. So there were various medicines that were restricted and different types of restrictions. So the greatest decrease in medicine suicide was seen when dextropropoxyphene, which is an opioid that's highly cardiotoxic, was withdrawn from the market in England and Wales. All the barbiturate interventions were effective. And then when we looked at changes in other methods of suicide, 5 studies reported a slight decrease in other methods, while the 2 blue studies, which were the pack size, they reported no significant change. So for pesticides, there were also various chemicals that were subject to a ban or a occupational license. So 6 studies reported a decrease in suicide by pesticides, and the study in Greece had no significant change. When we looked at changes in other methods of suicide, 2 studies reported a slight decrease and 4 studies reported no significant change. So it is also important to note that this is at a population level, so it can have a big impact in our population. So with Sri Lanka, the ban of the 3 pesticides is reported to save an estimated 93,000 lives or suicides prevented over 20 years, which is a big impact. So overall, means restriction helps to save lives, especially when the method of suicide is common and or lethal. So we also did a scatter plot, which you can see here in our paper. So we calculated the net change in suicide rate per 100,000 people, and we graphed suicide by the poison and changes in suicide by other methods. So the sentence here is taken from the paper, and it basically states that the change in method-specific suicide rate was a significant decrease, but the changes in other methods of suicide was not statistically significant change. So there are limitations to our study. We did not account for the differences because of different time periods, and there can also be some economic and social factors. Because we only did English studies, that may be why we did not find studies in Africa or South America. And when we assessed the studies for a risk of bias, according to the Robbins eye tool, generally they had a moderate to high risk of bias. So the graph here is just an example of an interrupted time series, which is one of the best methods to evaluate interventions because it looks at the slope or pre-intervention changes and can quantify the extent of change after an intervention. But there were only 4 studies in our review that did an interrupted time series. So some future research could examine regional means restriction as well as some upcoming interventions in Australia. So paracetamol is being proposed to have a pack size limit down to 16 or 50 tablets in Australia. And the modified release paracetamol is proposed to go from over-the-counter to prescription only. So we could evaluate changes in suicide rate after these interventions. So this paper is published in JAMA Health Forum as association between means restriction of poison and method-specific suicide rates. And you can read more to find out about domestic gas and motor vehicle exhaust interventions. So from this paper, we had a theme that it was important to restrict poisons that are common and or lethal. And we also wanted to focus on the potential for means restriction in Australia. So as a result of this, we worked with the Ashley protocol. So this was a study conceptualized by Dr. Kate Shetty, which is Australian suicide prevention using health-linked data, and it's in BMJ. So this is a retrospective study that analyzes cases of suicide in Australia with de-identified data. So the aims are to identify some risk factors and other associations to help with making recommendations for suicide prevention. And the sources of data include coroner's data, medicine history, which is in the PBS or pharmaceutical benefit scheme, and health services, which is the Medicare benefit scheme, And this can tell us what medicines and services were accessed before a death by suicide. So the second paper of my thesis was substances detected in poisoning and non-poisoning related suicides in Australia. So in Australia, there are at least 3,000 suicides that occur every year, and 20% of these involve poisoning. Medicines are used to treat health conditions which predispose suicide risk, such as depression and chronic pain. However, medicines can also be used for intentional self-poisoning. So supplying medicines is a balance between treating medical conditions while trying to minimize the risks from medicine misuse and self-harm. So this paper now uses coroner's data to tell us exactly what substances were present at the time of a death by suicide. So it is currently unknown how the post-mortem toxicology profile differ in people who die by poisoning suicides compared to other non-poisoning methods of suicide. And identifying these differences can help to inform targeted suicide prevention strategies, such as substances that should be considered for means restriction in the future, as well as some medicine profiles that are associated with poisoning. Aims of our study were to identify the most common substance classes and combinations in the suicide cohort, as well as to identify the most common individual substances and to analyze concentrations of some selected substances. And all of these were divided into poisoning versus non-poisoning related suicides in Australia. So we extracted data on suicides in Australia from 2013 to 19 from the National Coronial Information System. We coded all substances that were detected in the toxicology reports, and we classified the cause of death as poisoning related if poisoning contributed to the cause of death to any extent. This means that a mixed method of death, such as poisoning combined with another method, was still classified as poisoning related. We calculated prevalence ratio, which is similar to relative risk, and this represents how common a substance was in the poisoning compared to the non-poisoning related suicide. So after data cleaning, we had the toxicology data for about 13,600 suicides. So this was divided as 25% being a poisoning-related cause of death. So we divided the poisoning suicides further into poisonings that involved medicines or drugs, which includes illicit drugs and over-the-counter medicines, and also poisonings that involve non-therapeutic gases and chemicals. So we did the classification based on the coroner's judgment, or what the coroner said were the causes of death. We looked at the cases by sex demographic. We noted that for the non-poisoning suicides and the poisonings that involve the non-therapeutic gases and chemicals, it was 80% male and 20% female. However, for the poisonings that involved medicines or drugs, it was 50% male and female. So we've done another forest plot here with the prevalence ratio of the substance classes that were detected in suicides. So we've listed them with the most common substance being first and presented in descending order. So the prevalence ratio shows us whether the substances were more likely to be detected in poisoning compared to non-poisoning suicides, with the ones more common in poisoning suicides being greater than 1. So these were not mutually exclusive rows, so multiple findings from one person can contribute to multiple rows here. So most of the medicine classes were 1.5 to 3 times more likely to be detected in a poisoning suicide. And then the gases and chemicals had the highest ratio to be detected in a poisoning suicide. There was no statistically significant difference in the distribution of alcohol between the poisoning and non-poisoning suicides, while the illicit drugs in blue which are the cannabinoids and amphetamines, were more likely to be detected in the non-poisoning suicides. So the substances or medicines can still be present because they are used therapeutically, which is why they can be detected in the non-poisoning suicides. When we consider the cohort size, antidepressants and benzodiazepines are detected in over 30% of the suicide cohort. However, this is not a surprising finding, as these are the main treatments for depression and anxiety, which are associated with suicide. However, we also note that alcohol is present in 30% of suicides as well. And there were 9 classes which are detected in over 10% of the suicide cohort, and this does include the cannabinoids and amphetamines. So substance combinations were very common. So the poisoning-related suicides had a greater number of substances and were also more likely to have a combination. We characterized the typical profiles for these different types of suicide. So the medicine poisonings often had additive toxicity, which is toxicity from an opioid combined with an analgesic or a sedative, while the poisonings that involved non-therapeutic gases and chemicals were often detected alone or with alcohol or an antidepressant only. For the non-poisoning suicides, the common profile of combinations was intoxication. So this was alcohol combined with a cannabinoid or an amphetamine, and also a profile of multiple psychotropic medicines, such as antidepressants combined with a benzodiazepine or antipsychotics, which does suggest multiple mental health conditions. So it is important to monitor specific medicine profiles, especially if those are toxic at high concentrations or lethal when taken in a combination. The high rate of medicine usage means that there are opportunities for intervention at the healthcare professional level. And we also discuss means restriction of poisons, including carbon monoxide, which was one of the leading poisons, and means restriction is also important for poisons because they cannot be monitored through other medicine-specific interventions. So it is also important for additional interventions for patients with a history of suicide ideation or previous suicide attempts. And we also talk about cautious prescribing. So cautious prescribing means to start patients with medicines that are less toxic in overdose or use the less toxic options as a first-line option for medical conditions. Healthcare professionals can also consider stage supply. So that is when exactly a week's worth of medicine is supplied and monitored by the doctor and pharmacist, and also disposal of medicines, especially old painkillers and sleeping tablets. This can be a protective measure for people in a household because a lot of poisoning attempts do use whatever is present in the household. So it is good to remove medicines when they are not needed anymore. So our study cannot assume any causal links between medicines and suicidality or these medicines increasing suicide risk. There are some forensic testing limitations, so some substances are not tested for in certain states and territories, so they will not be appearing in the data here. And substances that are prevalent are not necessarily contributory to the cause of death. And we have talked about the medicines and substances that are common, but they can also be common in the general population, so we address that in the next study. So this paper on substances detected is published in JAMA Psychiatry, and you can read this paper to find out more about our concentration analysis, as well as our age and sex adjusted calculations. So the third paper of my thesis was a case series study, which looked at the relative toxicity of medicines in medicine poisoning suicides in Australia. So this paper was a specific subgroup from the Ashley study. So this one used only poisoning suicides that involved medicine or drug poisoning. So the aims of this study were to compare medicines by relative toxicity. So this tells us about medicines which are the most likely or have high involvement in poisoning suicides. And we also compared medicines by lethality, which informs us about the danger of an overdose, or if multiple medicines were taken in an overdose, which one is the most toxic. So both measures are used to identify high-risk medicines. So to calculate toxicity, we used Fatal Toxicity Index, or FTI. So this is calculated as the count of the medicines divided by defined daily dose, which is a World Health Organization measure, which is basically just the average use of the medicines by the general Australian population. So for our count of medicines here, it is different to our previous study because our previous study looked at all substances that were detected. However, in this study, we looked at only medicines that were considered by the coroner to be contributing to the cause of death. So this was determined by either the coroner stating that the medicine is one of the causes of death, or the medicine matched the ICD-T code, which is T codes for poisoning. So basically, we ranked medicines by toxicity. So medicines with a high FTI are medicines that have a high frequency to be involved in poisoning suicides, but have a lower usage in the population. And there are some limitations to this, such as private prescriptions and over-the-counter sales not being included in the data. So we calculated FTIs for about 110 medicines, but in this graph, I'm only showing about the 30 medicines with the highest FTIs. So this is graphed on the plot with the highest FTIs on top. And we've also divided our medicines by drug class, which you can see in the colors here. So basically, the medicines with high FTIs, or that could be considered highly toxic, included barbiturates, sedatives, benzodiazepines, opioids, and antipsychotics. In contrast, medicines with low FTIs included medicines used for blood pressure and diabetes. We also noted that propranolol, which is in the middle here, had a high FTI compared to other cardiovascular medicines. So we also had dispensing history, which was through the data linkage of the Ashley study. So the data linkage tells us about the dispensing history of each individual with their usage of their PBS. So then we could calculate FTIs again and divide this into whether the medicine was dispensed within 1 year of death or not to the individual. So this can give us some estimates about medicines that are being diverted or misused, because these medicines will have lower rates of dispensing, and we can also consider if these medicines are known to have a street value, and maybe these medicines should be considered for stricter access requirements in the future. We can also look at medicines that are very monitorable. So medicines with high rates of dispensing mean that their dispensing frequency can be tracked through some prescription monitoring systems, and then we can make interventions to ensure that the frequency of dispensing is not too often, which can prevent people from stockpiling or getting a large amount of the medicine. So we have the same graph again, but now with the brackets show the percentages of PBS dispensings within 1 year and whether it was captured. So, for example, quinine had a PBS dispensing captured for about 20% of the subgroup. So in our study, The antidepressants, antipsychotics, and antiepileptics had high rates of dispensing to the individual, while the opioids, benzodiazepines, and other hypnosedatives had low rates of dispensing to the individual. So we also had a measure of case fatality. So case fatality uses the same numerator or count of medicines, and this is divided by calls to the New South Wales Poisons Information Centre. So we used phone calls that were for intentional self-poisoning, and this allows us to rank medicines by lethality. So medicines with a high lethality are medicines that have a higher rate of death per poisoning event or per overdose. However, we do call it an estimate in our study because using phone calls to the poison center is a rougher estimate than what other case fatality studies use, which is usually emergency hospital admissions with that medicine. So with our scatter plots here, we have graphed both the FTIs and the case fatality. So any medicines which are on the top right are considered higher risk because they have a high FTI and a high case fatality. So we also have the dotted line, which is the overall FTIs and overall case fatalities. So we just calculated an average value, which was the average for all of the medicines pulled together. So for our antidepressants here, it was the tricyclic antidepressants in the top right that had the highest toxicity rankings. So this does confirm what is already known, which is that tricyclic antidepressants tend to be more toxic than other antidepressants, especially the SSRIs. However, an interesting finding was that citalopram had a higher toxicity ranking than other SSRIs, and this is a similar finding to a study in the UK, and it may be because citalopram has effects on QT prolongation of the heart. So for opioids, the hydromorphone, morphine, methadone, and oxycodone had high toxicity rankings, and a similar findings were seen in studies in Newcastle and Finland. So if we compare buprenorphine, which has a lower toxicity ranking, this may be because it's often given transdermally, so it is more difficult to overdose on buprenorphine if it's given on a patch for pain relief, and it is also a partial agonist on the opioid receptors. However, both buprenorphine and methadone are used in opioid substitution therapy, but we do note the different toxicity rankings. For hypnosedatives here, generally the benzodiazepines and zopiclone had high toxicity rankings. And we also had phenobarbital, which was classified as a barbiturate, but that had also had a high toxicity ranking. So our study does have limitations. So the dispensed and non-dispensed FDIs had a lot of assumptions, which we have included in our paper. And we also assume that medicines were equally responsible for the cause of death. And we also know that there can be some inconsistencies with how coroners or ICD coding is done. So in the future, studies will be able to use real-time prescription monitoring. So this is real-time monitoring of prescription dispensing, and it will also address the limitation in our current study where we couldn't find out if a private prescription was dispensed or not, which is prescriptions off the PBS. We also talk about long-acting injections. So we found that second-generation antipsychotics were less toxic than the first generation, and these can be delivered through a long-acting injection, which can reduce the availability of these medicines as a poisoning method. And opioid substitution therapy can also be delivered as a long-acting injection. It is also important to assess suicide ideation when these high-risk medicines are used off-label. So, for example, a tricyclic antidepressant for nerve pain, and also assess suicide ideation for the high-risk non-psychotropic medicines, such as quinine for arthritis conditions, which was found to be highly toxic. So this paper is not published yet, but do watch this space as I continue submitting to journals. So overall, our themes were that it is important to restrict poisons that are common and or lethal in the population. So our second paper focused more on poisons that were common. Our third paper focused on poisons that were lethal. And in our papers and the PhD thesis, we then named the following specific medicines, which should be considered as targets for means restriction or have additional monitoring done by healthcare professionals. So these rows are opioids, and then anti-epileptics, and then antidepressants, antipsychotics, and non-psychotropic medicine. So we've got oxycodone and quetiapine highlighted because these two medicines were very common and also quite high in the lethal rankings. So overall, it is important to continue monitoring suicide rates and methods, especially the lethal methods. So when we focus on suicide prevention, it is also important to remember that a large portion of poisoning is due to mixed drug toxicity. So that can be targeted as a method of poisoning as well. And we've also shown that there are advantages of using coroner's data because coroner's data is comprehensive and can identify the individual medicines. So studies with coroner's data can support other studies which are done in the hospital or government level because those studies tend to use broader drug classes. So the messages of my thesis also include that it is important to continue suicide prevention research in both high and low income countries. And means restriction should be used as a synergistic suicide prevention with other suicide prevention interventions. So this is especially other national suicide prevention interventions, as well as considering some psychological and social support that an individual might need. And the overall goal is to reduce the harms or risk of medicines while continuing to give patient care. So partial methods of means restriction were also effective. So partially restricting a medicine may be a good way to reduce poisonings or harms by the medicine, but also allowing the medicine to be available to people that need it. So thank you for listening to my presentation. My email is here, and I would like to thank my supervisors, which are Rose, Nick, and Kate, as well as my co-authors and data custodians at the NCIS. Thank you.
Fantastic. Thank you so much, Jessy. That was such an impressive body of work and really showcasing a different perspective on alcohol and other drug use from the pharmacy perspective. Just a reminder to please put your questions into the Q&A if you have any. But for now, I will invite our panelist, Dr. Rose Cairns, to please turn their camera on. Hey, Rose. Obviously, following that amazing presentation, I'm sure you have a lot of thoughts, and it'd be great to hear some of your reflections on some of the work that Jessy just presented.
Yeah, look, I think Jessy's done a fantastic job in her PhD of pulling all this together, and some really painstaking work as well in getting all the individual toxicology results out of the NCIS, which took a long time. And I think there's some really great take-home messages and some sort of clinical implications of this as well. I've always felt that means restriction is a bit of a neglected area in terms of suicide prevention, especially when you look at how much evidence there is for it, actually. And I think medicines and poisoning is a great place to start because of how common medicine overdose is in Australia. Not only the sort of 20% that Jessy mentioned, but also in the non-fatal overdose space, medicines are very common. And there's also something that we can do. There's the modifiable. We can do things that strike the balance between having access to people who need it, but also not allowing vulnerable people in our community to harm themselves. So I think I just wanted to underscore a point Jessy already made, is that a lot of suicides are a result of very impulsive events. So restricting harmful substances in and around the home is potentially very impactful, not only for the individual that that substance was prescribed to, but their family. And we're seeing, especially with teenagers, big upticks in self-harm amongst that cohort. So I think there's some really important take-home messages here and some low-hanging fruit that isn't really being done that much. Things like stage supply to people who might be at high risk, and the other interventions that Jessy mentioned. So it was great to have that all summarised, I think. And I guess one final reflection, with my clinical work at the Poisons Information Centre, is that, it's really nice to see some of the stuff that we've felt, things like the risks with citalopram and quetiapine that we've sort of seen clinically in cases, to see that, in big data sets, these population data sets, to see that that is a risk, and to have like that robust evidence behind some of those clinical, risk assessments that we have. So I think, it's a massive amount of work that's gone into this PhD, and hopefully a launching point for other studies as well.
Yeah, thank you so much for those reflections. Going off of what you've actually said, I just wonder, in terms of intervening in suicide means, how do you think that we could create strategies around substances that perhaps that is maybe not as possible for? So, for example, alcohol was seen in a third of the poisonings. How would you go about intervention in terms of stage supply for something that is so freely accessible? Or if there were other intervention strategies you could think of.
Yeah. Well, alcohol policy is very complicated. Ideally, we'd be able to think of strategies which can reduce like binge drinking and harms from binge drinking, because we also know that alcohol can affect people's like mental state and decision making, and even more so when they're in a crisis. And then also a balance between informing patients about the effects of mixing their medicines with alcohol, but not wanting to encourage that either.
Yeah.
Yeah.
I wish Kate Chitty was here, because alcohol and
Yeah.
suicide is her real focus. But look, I think the main thing is, impulsivity. When people are using too much alcohol, that would be my concern, is that it would increase the risk in that way, as well as, of course, additive toxicity as a sedative. But as Jessy showed, it was about equal in the poisoning versus non-poisoning suicides. Very difficult to restrict alcohol. So I think that's why restricting other things, so, if they've got opioids at home, or quetiapine or benzos, or anything that can cause additive toxicity, I think that's why this can have a role, really, because I think, while it would be wonderful to stop these self-harm, self-poisoning events from happening in the first place, that's a much harder problem to solve than making each event less likely to be lethal, I think. Yeah.
Yeah, I think that's a good answer to quite a large question that I posed today. Maybe I'll add another question, just once again, stealing the limelight for a little bit. I saw that there was a third of antidepressants, benzodiazepines, and alcohol, as we were just touching on then. Obviously, there's a really large comorbidity there, and you could assume that antidepressants are for depressive disorders, benzodiazepines perhaps for anxiety disorders. There's also overlap in that benzodiazepines are often used for withdrawal from alcohol. With all of these comorbidities and interactions, where people may actually need to have a level of supply of each of these substances to help with symptoms, how would you approach that when you're coming from a dual diagnosis perspective?
Jessy, did you want to, or did you want me to
Yeah,
have
that's
a go
a
at that
good
one
question. Also a long question.
Sorry.
I mean, I didn't cover it in my PhD, but Dr. Kate Chitty also looked at Medicare services and health services that people accessed. So I guess there is potential to monitor like people's medicine use and then also any treatment or rehab that they might need. But then from, I guess, the clinician point of view, it's being very careful about the selection of which antidepressant you give, which benzodiazepine you give, and yeah, supplying them in smaller quantities.
Yeah, I agree. I mean, like whenever you talk about means restriction, people think that you're trying to ban all these medicines, and I think that's not the case. It's just about making sure we're using them in the most safe way that we can. And you know, while it might be, I guess, a bit inconvenient, the stage supply I think would really work, because it just means that that individual doesn't have the massive quantities that can cause them more life-threatening overdose. They just don't have access to them. So I think in terms of, you know, benzos for alcohol use disorder and withdrawal, people with benzo treatment are usually undergoing sort of quite frequent monitoring, and I think that things like stage supply wouldn't be out of the question there. Yeah.
Yeah, I think that's a great point. Just highlighting that stage supply doesn't mean a complete cutoff. It's just reducing the risk of harm, which I think is obviously a great perspective to have when looking at alcohol and other drug use. We do have a question related to methamphetamine overdoses. And I think it is more a pharmacy general question, so I'm not sure how related it might be. But if there is any medicines that could be used in the event of methamphetamine overdose.
Yeah, look, there's not a specific antidote to methamphetamine like there is for opioids. You know, you got the naloxone, but with methamphetamine overdose, generally it's treated with supportive care, including use of benzodiazepines to reverse some of those toxic effects. It's basically aggressive supportive care rather than a specific receptor level antidote. Yeah.
Thank you for that. I don't think there are any more Q&A questions coming through. Please feel free to put more questions in there that come up if you do have any. I don't have any more particular questions to ask. Perhaps, Rose, you have some for Jessy. Obviously, as a PhD supervisor, I'm sure you've asked many questions over the years, but maybe something that's come up during the presentation.
Well, I guess it's always nice once you're at the end of a PhD to reflect on, if you had another 3 years, what would you do? Would you do things differently? Is there a burning question that you would like to answer, or, you know, a new data set you'd love to link into Ashley and answer another research question, Jessy?
The Ashley study, we've sort of done some of the PBS analysis and toxicology, and then we've done the MBS analysis. So I think, yeah, linking all three and just characterizing people very well with like people's needs, people's behaviors, and medicine like history would be good. I'm not sure how I feel about whether anything needs to be rewritten. I mean, there's certainly lessons I've learned with like best ways of writing things and collecting and analyzing data, but I think that's for every PhD student. Yeah.
Of course, I'm not saying you need to rewrite it.
Yeah.
Just as in, like, you know, I think with research, everyone can sort of empathize with the fact that you have to, there's all these really great ideas that you have, and you have to kind of focus on a couple because everything actually takes so much longer than you'd think. So, yes, whether there was any burning questions left unanswered there. There's a couple of questions in the Q&A now, I think.
Yeah, I was just looking at them. So we do have a few more questions. So Joe has asked, why do you think there's been a dramatic decrease in CO poisoning given it is still emitted in cars with catalytic converters?
So this one is in my first paper on the means restriction, but I didn't have time to include it in too much detail. But we do analyze a lot of studies. So most cars that are fitted with catalytic converters, this reduces how much carbon monoxide is emitted. So overall, there is quite a high decrease in suicide by motor vehicle exhaust, which is the carbon monoxide inhalation. But at the same time, there is still a significant number of carbon monoxide suicides in Australia, but it is less than what it was before.
Yeah,
I
think
I'm
catalytic
not sure
convert. Oh, sorry.
Sorry, you go, Rose.
No, you go. Oh, okay. I was just gonna, add that, it's actually been one of the really successful means restrictions, I think, catalytic converters. Obviously there's multiple reasons that change was made, but the dramatic decrease, I think it all comes back to, that Paracelsus quote, the dose makes the poison. So while there is still some carbon monoxide being emitted, it's just not that much that causes the really rapid onset loss of consciousness and death. So of course it is still possible, but it's just a lot less likely with the lower proportion, lower percentage that's emitted. Yeah.
Fantastic. And I'll just ask the next question, which is around antidote availability and efficacy, and whether it would change the findings from this study. My understanding would be something like opioids, which perhaps has a mechanism to reduce a potential poisoning.
Yes. Jessy, do you have any thoughts on that one?
Yeah, so in my third paper, I was careful to note when some of the medicines that were present were there because of hospital or resuscitation treatment. So that will be like sort of clarified in the study. But in terms of yeah, I
think it's
think
more about
antidote availability does mean that timely medical treatment would lead to lower lethality.
Yeah, I guess the thing is like opioids are still really up there and naloxone's been available.
Yeah.
A lot of these deaths are occurring outside of hospital, people who aren't seeking help. Yeah, so while it's great to have antidotes, they only work for, it's sort of like what you were talking about in your population approach, Jessy, like people who seek help, they're sort of different to people who don't. And while I think things like take-home naloxone are amazing public health interventions, I still think even if you had an antidote to every single thing, means restriction would still have a role for those people who don't seek help.
Yeah, so yeah, we also talk a lot about like timely medical intervention. And if means restriction can delay your suicide attempts, then there is more time potentially for someone to seek help or for someone else to call for help.
Yeah.
Yeah.
I think that's a really good point perhaps to end on is there's not really a silver bullet to suicide. It's so multifaceted in the associations and determinants of circumstances and so many other factors that even if you have an antidote, it doesn't mean that you're able to prevent it in every circumstance. I'd just like to say thank you both for one, a wonderful presentation, and two, Rose, for joining us to give us some extremely interesting insights. I'm definitely out of my depth in this field, so it's great to have you both providing insights into it. Do you have any final words you'd like to say before we let you go?
Oh, thanks for having me.
Yes,
it's been great.
No, the pleasure is all ours. So thank you both. Before I let the audience go as well, I would just like to touch on some upcoming webinars that you would have already received the invites for, but you can also access from our NDARC website. So next week on the 22nd of February, we will be looking at measuring and preventing substance-related injury events with Dr. Georgina Lau from Monash University. And the week following that, on the 29th of February, we will have Professor Keith Humphreys from Stanford University presenting on translating science into more effective addiction-related policies. So as I said before, please follow us on LinkedIn, which we now have, and you can also register there. Otherwise, you can find more information on our website. Thank you so much for joining us today, and hopefully see you soon.